Good evening, all.
Yeah, good evening, ma'am.
Good evening. So is my voice clear to all?
Yes.
Okay, great. Thank you. Screen PPT. छोटा भी लगा है। Okay. So good evening, everyone. Is my PPT is visible to everyone?
Yes.
Yeah.
Okay. Thank
Yes,
you.
ma'am.
Okay. So we'll start with today's session then. So I'm Dr. Sharvari, and I am happy and excited to interact with all of you today on this Medusa's Gas platform. So EDAIC 2 is definitely a prestigious exam, and I gave my EDAIC part 2 actually in Germany in 2014, and the exam is conducted so meticulously and so respectfully that the examination day is actually going to be, something like your lifetime experience. So let's start with today's preparation. So my topic is fetal circulation and congenital heart diseases. So we have 3 volunteers today. I think Dr. Gitu, Dr. Deepak, and Dr. Abhinav. So they can just, start their videos. Can you do that?
Yeah.
Okay. Okay, thank you. So we'll start with our viva sessions. I will start with Dr. Abhinav. Okay. So what are the shunts present in fetal circulation? Are you ready, Dr. Abhinav?
Yes, ma'am.
Okay. So first question is, what are the shunts present in fetal circulation?
So there are two vascular shunts that are present in fetal circulation. It includes ductus venosus and ductus arteriosus. And apart
Okay.
from that, there's also a defect in the atrial septum, that is the foramen ovale.
Okay. And just briefly, can you tell me that what they connect, the vascular shunt, what they connect?
So the ductus venosus, what it does is the blood, the oxygenated blood that is coming from the umbilical vein, it takes and it bypasses the liver circulation and makes it join the IVC. So approximately whatever is coming from the umbilical vein, only 40% goes to the liver circulation. The rest 60% via the venosus goes to the IVC that eventually drains into the right atrium. Uh,
Okay.
the ductus arteriosus, what it does is it's a connection between the pulmonary artery and the descending aorta. So
Okay.
its main role is that the blood that is, it does not allow the blood to go into the immature pulmonary system, and because it provides a low resistance pathway.
So,
So
Dr. Abhinav, when you are asked, what just what they connect, let the answer be precise to what they connect, so that there is a space for other questions. So you have answered perfectly. So you answered about two vascular shunts, and foramen ovale you have already answered. So perfectly, this kind of diagram actually helps you. So you can draw the diagram if this question is put up to you as an opening question. You can draw the diagram, schematic diagram, and be prepared to answer the question easily. Okay. So all of you know this diagram where RA to LA there is a shunt shown, and ductus venosus and ductus arteriosus. That was a good answer. Uh, Next question, actually, I want to ask, can you describe fetal circulation? So I would like to ask this question to Dr. Geethu. You would like to answer this?
Yes, ma'am.
Sure, go ahead.
So the fetal circulation starts with oxygenated from the umbilical vein, which is passing through the liver, which that passes and connects to the IVC through ductus venosus, and the inferior vena cava blood mixes with the SVC through, and the right blood enters right atrium, where maximum part of blood is shunted to the left atrium through foramen ovale to the left atrium. And the remaining part of the blood which enters from the right atrium to the right ventricle enters the pulmonary artery. Since the pulmonary vascular resistance is very high in the fetus, the blood which entered the pulmonary artery is getting shunted to the aorta also. And from the left atrium, which got shunted from the right atrium, it enters the left ventricle and to the aorta.
Which
so
aorta?
then left ventricle to the ascending aorta.
Okay. Okay, great. That was a good answer.
Yeah.
So, just as she mentioned correctly, I'm just trying to summarize that most umbilical blood shunts to ductus venosus to IVC. 1/3 goes to LA through foramen ovale, and the rest mixes with SVC to enter right ventricle, as she said. Okay. So, LA blood further mixes with pulmonary veins and enters LV. LV goes to ascending aorta, and small amount of RV blood goes to pulmonary trunk. But as the PVR is high, majority goes to descending aorta through ductus arteriosus. So it was a good answer. So next question I would like to ask Dr. Abhinav. Would you like to answer? How
yes.
is preferential oxygenation to major organs is achieved in fetal circulation?
So what happens in fetal circulation, as our doctor previously just described,
Yes.
the blood that is shunted via foramen ovale, that is the oxygenated blood. And this goes via from the left atrium to left ventricle, and from there ascending aorta. This oxygenated blood is supplied from the left ventricle to the upper part of the body, the organs which require the most of the oxygen, that is the brain and the heart. And this is one of the differences in fetal circulation, that the right ventricle pumps the almost deoxygenated blood to the lower parts of the body,
Yes.
whereas preferentially via the foramen ovale, the oxygenated blood goes to the major organs, that is the brain and the heart.
Okay. So actually, this was the diagram I had put in our WhatsApp group, right? So you have told me exactly the correct answer. So you can see that umbilical vein, can you see that umbilical vein saturation is nearly 90%? Okay. And, I had asked one quiz also regarding that SVC, as the, brain drains maximum oxygen, the saturation is lowest. Okay. But there is a mechanism that oxygenated IVC blood, preferentially it gets streamed through foramen oval from RA to LA and then to LV, so that it can perfuse brain, coronaries, and upper extremities. So that is how the preferential oxygenation is maintained in fetal circulation. So one thing I wanted to tell here is the pressure, PO2 in kilopascals or in millimeters of mercury, the numbers are actually not expected. We should not remember all the numbers, okay? But, the saturation differences in all these chambers is crucial to remember. So can you just see that 90% is the saturation in umbilical vein, okay? And can you tell me that what is the saturation in descending aorta through the figure?
58.
Yeah, here you can 50%. You are right.
Mm.
And where is it? All right. So ascending aorta, it is nearly 65%. Can you see that also?
Yes.
Okay, so these numbers, are easy to remember and they are important to remember, but the pressures we are not expected to remember the exact numbers about pressure. So that was a good answer, regarding preferential oxygenation. So the next crucial question is, what are the changes in fetal circulation at birth? Dr. Deepak, can you answer this question?
Yeah, sure, miss. So at the birth, when the fetus, the baby takes the first cry, so
Okay.
with this the oxygen is the negative pressure is generated, and around 80 ml of oxygen or air is taken inside the lungs. That causes the pulmonary vascular resistance to decrease,
Okay.
and that causes the blood flow from right ventricle through the pulmonary artery to the lungs.
Okay.
Now, with the clamping of the umbilical cord, the systemic vascular resistance also increases.
Yes,
And
perfect.
because of this the differential of increased systemic vascular resistance in comparison to the pulmonary vascular resistance, foramen oval closes.
Okay.
Now, as the blood is passing through the oxygenated blood is passing through the ductus arteriosus, because of this difference, the ductus arteriosus closes within the 24 hours, but that's the only physiological closure. Complete closure took around 3 weeks for complete closure.
Very good.
Now, if by any chance, if there is hypoxia or acidosis or hypercarbia, then the pulmonary vascular resistance got increased and the fetal circulation is persisted. So that is called the transitional circulation or the persistent pulmonary hypertension.
Okay. So this was an extra answer. I mean, that is a different question. What is persistent fetal circulation? So basically, bullet answers, like, what happens at birth. So you answered perfectly. Just 3 points. First is clamping of cord, and you said it perfectly. SVR rises, blood detecting to RA is reduced. So there is a difference in pressures among LA and RA. That gives rise to functional closure of foramen oval. Okay. Second point would be first gas, what it caused. So it PVR falls because of sudden lung expansion in fluid-filled lungs, and then pulmonary circulation is increased. So more and more blood coming to LA and giving rise to more and more pressures on left side. And third point also he perfectly covered, that pressure reversal between aorta and pulmonary artery, that gives rise to closure of ductus arteriosus. So I just want to say something that, exact timing of closure, what time anatomical closure happens, it's okay if we don't remember exact timing. So basically what we should know is there is, the earliest closure is always functional closure, and anatomical closure happens over the time of few weeks, and which is also reversible due to certain triggers. And he already mentioned the triggers, we will see them in a few minutes. That was good answer. Very nice. Now I will ask this question to Dr. Gitu.
Yes, ma'am.
So what is the role of prostaglandins in closure of ductus arteriosus?
Prostaglandins, PGE2 and PGI2 keeps the ductus arteriosus open for
Very good.
so we use this prostaglandins for duct dependent circulation to keep the ductus arteriosus open. The duct dependent circulation conditions, for example, these are transposition of great arteries and pulmonary atresia stenosis in top circulation.
Okay.
And
that is a perfect answer. Excellent answer, actually. So you said it perfectly that PGE1 relaxes ductal musculature and increases flow, and why we want it. We want our goal is to maintain, reopen or enlarge existing ductus arteriosus. So conditions also you have mentioned perfectly, that lesions with decreased pulmonary blood flow or lesions with left-sided outflow obstruction. What I just want to highlight here is whenever we want to, keep ductus arteriosus patent, we can aim both sides. We may want left to right or right to left shunting. So that depends on what the pathology is. Okay. So that is why there are example lesions with decreased pulmonary blood flow or lesions with left-sided outflow. So both sided. So dose is around 0.05 to 0.1 mics per kg per minute. Mostly it is given, always it is given as infusion actually. And on the other hand, prostaglandin antagonist, what will it do?
It causes closure.
Yeah, correct.
Endomycin.
Very nice, very nice. You mentioned it perfectly. So this is very, a favorite question I would say regarding fetal circulation. What are the factors affecting pulmonary vascular resistance? Dr. Deepak or Dr. Abhinav, anybody?
Yeah. So the factors which affect pulmonary vascular resistance are basically the hypoxia, hypercarbia, then acidosis, hypothermia. All these factors, pain, all these factors increases the pulmonary vascular resistance.
That is correct answer. Correct answer. So not about only this topic, but otherwise also, SVR and PVR are very favorite questions. So factor affecting it, you have to know, and it is related to multiple topics. So it is kind of, you have to know it thoroughly. That was the perfect answer. And Dr. Deepak, as you already answered this, I will ask this question to Dr. Gitu, that what is persistent fetal circulation? Have you heard this term and what is it?
Ma'am, because of the factors which increases the pulmonary vascular resistance, like hypoxia, hypercarbia, acidosis, and hypothermia, even after birth, the fetal circulation persists. All the ductus venosus, arteriosus, and foramen ovale.
Okay.
So then it is persistent fetal circulation. We also call it as transitional circulation.
That is a perfect thing. So only thing we have to remember is period of transition is always unstable, as there is anatomical closure has not happened with any of these shunts. So it is always reversible. And what are the triggers which cause them? So I've just tried to mention the triggers. So sepsis, prematurity, the state of ductus arteriosus and foramen ovale, and hypoxia, hypercarbia, acidosis, they all raise PVR, trigger right to left shunting through whatever way they can, either through foramen ovale, either through ductus arteriosus. That whole process triggers further hypoxia and further increases PVR. So if you see persistent fetal circulation, what can be the treatment? What do you feel?
Now we can try to avoid the triggering factors by correcting normothermia and acidosis and and hypercarbia.
So keeping babies warm, pink, and wet. So majority things we have tackled. We have tackled hypercarbia, acidosis. We have to correct, as you said, triggering factors and changes in ventilating strategies, CPAP or mechanical ventilation if needed, administration of surfactant if the prematurity has been the triggering factor. So correcting all these things will correct the pathology also. That was a correct answer. So classification is always a favorite thing in EDAIC 2 vivas. Broadly, how would you classify congenital heart diseases? Dr. Abhinav, can you answer this?
Yes, ma'am. So we can classify congenital heart disease based on whether they are cyanotic or acyanotic. This broadly means whether they are going through the pulmonary vasculature or they are not going through the pulmonary vasculature. So cyanotic lung diseases would include tetralogy of Fallot, pulmonary atresia,
Okay.
then total anomalous pulmonary vasculature, and transposition of the great arteries.
Okay.
And then considering acyanotic, it would be the ones that are causing left to right shunt. So this would include the septal defects, that is the ASD, VSD, and patent ductus arteriosus.
Okay. Okay. So anytime we are asked to classify, it's always with examples, as you did correctly right now. Okay, that was perfect answer. So congenital heart diseases can be broadly classified into acyanotic and cyanotic, and then they are further classified according to the way I have done. So can you read it and give me examples once again?
So congenital
Can
heart disease.
somebody else also can like somebody else who wishes to volunteer for this question?
Can I?
Yeah, please go ahead.
Yeah, okay. So acyanotic left to right shunt includes atrial septal defect, ventricular septal defect, patent ductus arteriosus. Then
Correct.
the obstructive defect includes the coarctation of aorta. Then cyanotic, in increased pulmonary blood flow, there is tetralogy of Fallot. Then
no. Wait for a second. So obstructive it is correctly as you say coarctation. It can be any other valvular stenosis like we expect in adults. They can present congenitally also. So
okay.
Any other LV outflow tract or RV outflow tract. They can present congenitally also. Okay. So now we move to cyanotic. Please go ahead.
Yeah. So in cyanotic, in decreased pulmonary blood flow, it includes like truncus arteriosus, tricuspid atresia, then
so basically TOF is our favorite example when there is
TOF is increased pulmonary TOF is also decreased pulmonary blood flow, then
and rest all complicated things, TGA, TAPVC, they present variety
with increased pulmonary blood flow.
Yes. So I think you got to know what I meant to say. So we classified and then we further classified and then we presented our examples. So actually in one textbook I found this question, so I am asking it here. That is there any other way to classify congenital heart diseases? Dr. Gitu actually had mentioned one of the answers she mentioned. Is there any other way?
Ma'am, I read this classification in Guy Pediatrics. It can be classified as a pre-tricuspid or post-tricuspid shunts, and VSD and pulmonary stenosis, and single ventricle physiology, duct-dependent lesions, and unfavorable streaming and parallel circulations. This classification I found in Guy, but this was very complicated.
Yeah, it was. So
we can classify it as simply duct dependent and duct independent. CHDs. Duct dependent would be anywhere where outflow is obstructed either from the left ventricle or the right ventricle. So in right ventricle is pulmonary atresia, left ventricle is something like coarctation of the aorta. So in both these conditions, we need a shunt to make sure that the blood keeps getting flow. Something like so we need a patent ductus arteriosus in these conditions. Duct independent lesions are those which do not require a patent ductus arteriosus.
Okay. So your answer is correct. Actually, they are classified as duct dependent and duct non-duct dependent. Very correct. So the only summary what I have to say here is ductus arteriosus has to be patent for survival of the baby. those conditions are obviously called as duct dependent congenital heart diseases, and vice versa for non-duct dependent. But as Dr. Abhinav correctly pointed, that they can further be classified as cyanotic and acyanotic depending what they present with. So this is just a kind of, you have to say the earlier classification only when it is asked for. When the question further triggers, what is the one more way to classify, you can answer duct dependent and non-duct dependent classification. That was correct answer actually. So this is kind of, memorizable question, like what are the associations of congenital heart diseases and any other syndromes? So do you know them?
So Down syndrome is associated with atrioventricular septal defects and the tetralogy of Fallot, and Turner syndrome is associated with occultation of aorta.
That was perfect. No, only these two are actually important.
Okay.
Yeah, so they can present isolated or with syndromes, as you said correctly. So Down syndrome is associated with atrioventricular septal defect and tetralogy, and Turner's is many times with coarctation of aorta. So that was correct answer. So what are the concerns, whenever you are dealing with a patient who is having a cyanotic heart disease? What are your concerns? Dr. Geethu, you would like to answer?
Yes, ma'am. So basically, acyanotic heart disease, mostly the shunting is from the left to right. So that leads
Yes.
to increased pulmonary blood flow, that leads to recurrent respiratory tract infection.
Yes,
And
correct.
so in a long standing, it can lead to congestive cardiac failure also. So
Yes.
in right heart, it mostly of the right heart failure. So
Okay.
and
Okay.
so yes, ma'am.
Very nice. So is infective endocarditis your major concern in a cyanotic heart disease? I just wish to know that.
No, ma'am.
No, ma'am. It happens in cyanotic mode.
Yes, you are right. Yes, you are right. So this is just, just representative case. I have chosen to put atrial septal defect, but ASD, VSD, PD, I mean, anything can be put up to here. So what you see, can anybody just, can anybody just see the picture? And this is actually taken from Ghai. So this is familiar to all of you. So what is happening here in ASD? Can somebody tell me that?
So in ASD, basically the foramen oval is patent. Now the left-sided pressures are more than the right-sided pressures. So from the left atrium, blood flows to the right atrium and also to the left ventricle. So from right atrium, the blood is coming through from the left atrium and from the systemic circulation, from the systemic venous return. So right atrium is overloaded, volume overloaded, so it got dilated. Then this increased volume is presented to the right ventricle, so it also got volume overloaded. And this increased volume is coming out to the pulmonary artery, which causes eventually pulmonary hypertension, causing later on pulmonary edema, and it then later causes us right heart failure, basically. Now, regarding the sounds, the more blood, from the left atrium, as the blood is flowing from the to the right side, right atrium, and the left ventricle, so the blood, the left atrium emptied out early. So the S1 is like, what should I say? It is accentuated, but it is narrow. But the S2, because more blood is coming through the right ventricle,
through pulmonary valve.
Through pulmonary valve. So this valve took time to close, and the S2 is it's like split widely.
Perfect.
It took time.
Yes, and it is so distended that changes in venous return with respiration are actually, they do not matter. So there are no changes with respiration. So S2 is wide fixed split. Okay, and S1, regarding S1 you have said. So this is just a diagrammatic representation, where we can see that right side is already overloaded, and the concerns you have all told perfectly. So we have pulmonary overflow, pulmonary edema, pulmonary hypertension, right heart failure, and there is one more term. So I want somebody to answer that. What is one more concern, which is isomerization? What is it? When you can face it? I want to know that. Dr. Abhinav?
So in these left to right shunts over a period of time, because of increased pulmonary vascular resistance, blood keeps flowing into the pulmonary vasculature. Pulmonary hypertension takes place, and this can actually reverse the shunt from left to right to left. And this will make it from an acyanotic to cyanotic heart disease.
Okay. So can it be triggered when patient is under anesthesia? Can it be triggered?
Yeah, in any condition that will increase the pulmonary vascular resistance, like hypoxia, hypercarbia, hypothermia, acidosis, can further increase the pulmonary vascular resistance and reverse the shunt.
Yes.
And any factors which decrease the systemic vascular resistance also can trigger.
Yeah, you are right. So if you are dealing a patient with a cyanotic heart disease, what would be your anesthesia goals? We had concerns. We know what are our concerns. So what are the goals if we anesthetize with a cyanotics?
So these patients will be having, since these patients have a left to right shunt, as we just mentioned, we won't like the SVR to fall too much. So the diastolic blood pressure should be maintained as it is pre-induction levels. We would also not want the patient to go into any condition that would trigger the pulmonary vascular resistance further. So we should make sure that the patient is warm, the patient does not have any acidosis, it's well oxygenated, and the PCO2 levels do not rise much.
Okay. So basically there is a nick here. I mean, what we want, if the patient already has a defect, which is a cyanotic left to right shunt, patient already has the defect. So what we want, I mean, we do not want any fluctuation in SVR and PVR, because what will happen is, if SVR is low and PVR is too high, what will happen? If SVR
Reversal
is
of the
too,
shunt.
yes, that means isomerization.
Cyanotic, yeah.
Correct?
Sorry,
Correct?
cyanotic.
Yeah, correct. So, and if the condition is other way around, like if PVR is too low and it can, if the reversal of these resistances can trigger the shunt flow to increase, too much increase in anesthesia. So we actually want to avoid any fluctuations in HVR and PVR. Okay. And we have already discussed the factors which affect PVR, which the factors like SVR is decreased because of drug-induced, anesthetic drug-induced vasodilation, bronchospasm. Okay, so infective endocarditis prophylaxis I have put here, but it matters definitely more in patients with cyanotic heart disease. And avoidance of air bubble also, paradoxical embolism risk is more in cyanotics, but at any congenital heart disease, we try to avoid air bubbles in our IV circulation. So if you have any child with congenital heart disease, how would you evaluate the child? Dr. Deepak, you wish to answer?
So, So for evaluation of congenital heart disease, first we'll like to know the history of the patient, what kind of lesion the patient is presented with. We'll do the complete systemic examination of the patient. Then we'll review the medications of the patients, what medications the patient is currently on. Then we'll assess any complication related to that congenital heart disease, like if the patient has got cyanosis, if the patient has got any kind of heart failure, then the patient is in pulmonary edema or not, then we'll order some investigations accordingly. Like we can investigate CBC, complete blood count. We'll order chest X-ray, especially we'll order electrocardiogram, and we'll order echocardiogram specifically. And if the patient is on diuretic, we'll order kidney function tests, including serum electrolyte also. So on this basis, we'll evaluate the kid.
So that was perfect answer. So only thing I want to emphasize here is go stepwise. So history. So history like functional activity, history of spells, history of recent chest infection, succurrence subcycle, the way we already answered in our previous examinations. Okay. And examinations, we will see anomalies because they are associated with these congenital heart diseases. Pallor, cyanosis, edema, any signs of heart failure are present. Type of murmur. Investigations, as he correctly said, CBC, hematocrit, chest X-ray, ECG, echo, and a baseline saturation at room air. That we should know. So when we evaluate, we get concerns. So we already discussed the concerns regarding for acyanotic heart diseases. And from history, examination, and investigation, we will try to know that what is the direction of shunt flow. We cannot know it exactly, but at least whether it is left to right or right to left, that we can judge by history examination. Echo will definitely help to know it perfectly, but prior to that. And then we come to goals. Goals also we already discussed. And then you can choose the way, the method you are comfortable with to anesthetize that child and present the safe and balanced anesthesia technique. So that is the perfect answer. So after that, Dr. Gitu,
Yes, ma'am.
this X-ray, this chest X-ray, is it visible?
Yes, ma'am.
Yeah. So can you comment about it?
Yes, ma'am. It is a boot-shaped heart, or we call it as core-ring sabot. So this type of chest X-ray comes in tetralogy of phallophysiology, which comprises 4 components. The basic embryological alternative happens because of the anterior portion of the infundibular septum that leads to overriding of the aorta, BST, pulmonary stenosis or right ventricular outflow tract obstruction.
I think you missed VSD.
Right ventricle.
RVH, yeah.
RVH.
If it comes with AST, it is called pentology.
Perfect. Yeah. So actually, I thought that you will answer wrong because and I suddenly purposely put this X-ray. But this is the very typical X-ray for tetralogy, as you said perfectly. But I want you to comment about pulmonary vasculature about this X-ray.
Ma'am, because of right ventricular outflow tract obstruction, in TOF, there will be pulmonary oligemia.
Yes, this is very extreme important thing to answer. So upturned apex because of RVH, giving boot-shaped appearance is the first thing. Then pulmonary oligemia is the second very important thing. And they also say that there is a concavity at the pulmonary area, but that is a third thing, plus or minus. But these 2 things at least are very important to answer. So it was a good answer. So after this X-ray, anybody wishes to answer for this X-ray? Dr. Abhinav?
Yes. Let's say cardiomegaly is there for sure.
Yes, perfect. Perfect.
Cause of cardiomegaly, I'm not sure, but there is cardiomegaly in this.
Pulmonary hyperemia is also seen.
You are perfectly right. Let us have a look at this X-ray and how we can appreciate pulmonary oligemia. And then if we see this X-ray, so there is definite pulmonary plethora.
Yes.
Okay. And cardiomegaly. Very nice. So we cannot comment more than this through just this X-ray. So this, we can just say that this may be the something like left to right shunt, but exact we cannot comment from this X-ray. So this is good. This is enough. So after this, we discuss the X-ray, and now we will just see the 4 components of tetralogy. And Dr. Abhinav, you can tell actually.
So the main problem in tetralogy of Fallot is there is overriding of arch of aorta and right ventricular outflow obstruction is there. Now, because of this, there is right ventricular hypertension and there is also a ventricular septal defect.
Okay. So VSD, you said perfectly, RVH, rather than pulmonic stenosis, it is actually right out ventricular
Right
outflow
ventricular
tract
outflow.
obstruction. Perfect. And it can be at different levels because it can be infundibular, it can be pulmonic, it can be subpulmonic, but it is outflow tract obstruction. And the fourth one, you said correctly, there is overriding aorta. So what happens? Pathophysiology of TOF, what happens? How do the babies present and what exactly happens in circulation for TOF? Dr. Geetu?
Yes, ma'am. So, because of the right ventricular outflow tract obstruction, the shunt will be from the right to left through the VSD. So, most commonly, patient presents with cyanosis. There will be history of cyanosis in younger this one neonates. There will be sweating. Sweating will be there during feeding, and they'll get EC fatigability during feeding. So because of the EC
cycle.
yes,
Yes.
So because of the EC fatigability, there will be poor growth.
Perfect. Yes.
Poor growth, and sometimes failure to thrive will be there. And in older children, when it comes to 3 to 4 years of age, there will be a history of cyanotic spells, which occurs during crying, agitation, which all increases the pulmonary vascular resistance. The conditions which all increases pulmonary vascular resistance leads to more of death spells. A history of knee chest position will be there, which is a protective mechanism for the cyanotic spells. Because knee chest position increases the systemic vascular resistance by compressing the femoral vessels.
That was correct answer. So it is actually our favorite, question. TOF is always our favorite topic, let it be MD, DNB or MBBS. So just I would say sequential answer. I mean, RVOT obstruction will lead to right ventricular hypertrophy, obviously. Okay. So when right-sided pressures are higher than left, right to left shunt will be established. But there is a time when right ventricle is decompressed and RV and LV pressure is near identical, and then the shunt is silent. Okay. But then what decides the further shunting is actually pulmonary stenosis. So more severe is the PS, severe is the right to left shunt, and then severe is cyanosis. Yes, you are right. So also decrease in systemic vascular resistance can increase right to left shunting. Okay. So one more thing I want to highlight here is what will be the relation of murmur, systolic murmur and cyanosis? What do you feel? Dr. Deepak?
Yes, so as you have mentioned here, so the intensity of murmur is inversely related to the pulmonary stenosis, because more the stenosis will be there, so more blood will be shunted to the left side. And
first you tell me that systolic murmur, from where it is coming? You are talking about shunt murmur or you are talking about pulmonary? Which murmur you are saying?
Basically, the flow murmur increases. More.
So pulmonary, pulmonary.
Yeah. So flow murmur increases with the severity of the stenosis, and the.
No, it is not like that. So more critical is the stenosis. Less flow will go there. So hardly there will be murmur. It's like that.
Flow through the VSD. Flow through the
No,
VSD.
flow through the, not through the VSD, through the pulmonary.
Okay.
Yeah. So
Okay.
shunt is mostly silent. We are talking about systolic
Okay.
murmur is the murmur. We are talking about PS murmur.
Okay.
Okay, so this is very important thing to remember. I wanted to highlight, so I put it up as last point. So what are the concerns? We discussed acyanotic heart diseases concerns. What are the cyanotic heart diseases concerns? When you anesthetize a patient with cyanotic heart disease, what would be your concerns? Dr. Deepak, you go ahead.
So, cyanotic heart disease basically present with right to left shunt. So these patients have low saturation, baseline low saturation, and they don't improve with the oxygenation also. These patients usually are present with polycythemia. So there is increase in the viscosity. So we need to give them fluids. Then these patients, because of right to left shunting, they have chances of paradoxical embolus. So we need to keep our IV fluids free of the air bubble. The IV induction is slower in these patients. So we should titrate our inhalation induction accordingly. But if we are choosing the IV induction agents, we should choose meticulously, because decreases in the SVR because of propofol, it reduces SVR more and increases the shunt fraction more. So the ketamine is the drug of choice in these patients. Then we have to balance between again the PVR and the SVR accordingly to balance the shunt, flow to the shunt.
Okay. Okay. So, yeah. So you have mentioned, I think, most of them. So polycythemia, why they will have polycythemia?
Because these patients have cyanosis, so body physiologically tries to compensate for decreased saturation. So
Perfect.
body physiologically increase the hemoglobin content, increase the hematocrit.
So it is compensatory mechanism for hypoxemia. You are perfectly right. Heart failure and then paradoxical embolism. Cerebrovascular accident, why they should present with it?
Because of this connection, if any emboli is there, that can pass through to the cerebral vessels, that can cause cerebrovascular accidents.
Yes, and also there is hyperviscous state. So hyperviscosity and thrombosis, they can also.
Yeah, that can also cause. Yeah, that will also cause. Yeah, CV.
Okay. So brain abscess, why they will present with brain abscess?
Brain abscess.
Can I, ma'am?
Yeah, you can answer, please.
Ma'am, actually, because it bypasses the pulmonary circulation where the organism, microorganisms, the filtering is bypassed, so they are more prone for abscess.
Okay. And as you already mentioned that impaired growth, impaired development, and risk of infective endocarditis is more when we have in cyanotic heart diseases, definitely. Okay. So what is terminology called as ping tech? What is it? Dr. Gitu, you will answer.
No.
Okay, so actually it is nothing great. I will just wish to tell. It is just condition where the pulmonary stenosis is minimal. So there is actually, just little adequate flow to enter into pulmonary circulation. So they are not blue, they are pink. So that is just called as pink tech. They have minimal valvular or subvalvular stenosis. Okay. And they will present with long, loud murmur. There will be flow murmur. This is not shunt murmur, this is flow murmur I'm talking about. And this is our typical question. What are TET spells or what are hypercyanotic spells? So what is the cycle of this hypercyanotic spell? Dr. Abhinav, are you there? Okay, I think he's not there. He's on call today. He messaged me earlier. So, Dr. Deepak.
So the hypercyanotic spells are conditions which which causes shunt to increase from the right to left side, causes the hypercyanosis. So anything which increases the PVR or decreases the SVR causes increased shunting from right to left, and that causes the cyanosis. And that will again cause the condition perpetuating this cycle. So like if the child is crying, if there is hypoxia, if there is hypercarbia, if there is acidosis, if there is pain, then it will causes increased shunting because of increased PVR, and that will cause a perpetuating cycle of increased right to left shunt.
Okay. So it will further trigger hypoxia.
Yes.
Correct. So it is exacerbation of hypoxemia, for that short duration. So infundibular spasm aggravates RVOT obstruction. Correct. It worsens right to left shunt, leads to severe cyanosis. So hypoxemia, and when there is hypoxemia, hypercarbia, acidosis, it is natural, response of body to give rise to hyperpnea. So the tachypnea. So this is the cycle which just leads to further hypoxemia, hypercyanotic spells. So how would you treat these hypercyanotic spells, Dr. Gitu?
Yes, ma'am. So the basic pathology here is infundibular spasm. So to relieve that spasm, we can use beta blockers, either propranolol or esmolol. And to decrease hyperpnea, we can use morphine. And if the triggering factor is acidosis, we can give bolus fluids. And we can intraoperatively, if the kid is going into TET spells, we can put the patient in knee chest position, which increases the systemic vascular resistance through compression of femoral vessel. Or sometimes during the procedure, if it is happening, we can even compress the descending aorta also, which also increases the systemic vascular resistance. So which decreases this cyanotic spell.
Okay, that was perfect answer. So just a minute. Yeah. So how would you treat knee chest treat hypercyanotic spells? So knee chest position to compress femorals and raise SVR. Fluid bolus, phenylephrine to raise SVR again. Treat the triggers or treat acidosis, the hypoxemia, hypercarbia, which will lead to acidosis. Treat it. Beta blockers, did you mention beta blocker also? I think you mentioned.
Yes, ma'am. Yes.
Okay, so how would it treat the spell?
Ma'am, it relieves the spasm, infundibular spasm.
It will release the infundibular spasm. And a role of oxygen is actually not much because there is the pathology is different and there is right to left shunt, but oxygen acts as the last point. And one more thing, you had said morphine to treat hyperpnea. That is also correct. Very good. So
And oxygen, sorry to interrupt, but oxygen also causes PVR to fall. So
yes.
It will also help that way.
Yes, but there is, that's why I said it is written as the last measure, but first the measure to affect raise SVR, they are taken as priority basis. All the measures to raise SVR.
Yes, you are right, but oxygen will not correct the hypoxemia as such.
Yes. Next question is, where would you consider infective endocarditis prophylaxis? In which congenital heart diseases? Dr. Gitu?
Yes, ma'am. Ma'am, actually, if in TOF, we can all the cyanotic heart disease, And if the patient is having past history of proven infective endocarditis, we can give prophylaxis, or untreated shunts, previous history of cyanotic heart disease, which is untreated, we can give. And all the dental procedures will give infective endocarditis prophylaxis.
Okay, you are right. Basically, I want you all to read more about it. There, because there are two things actually: the surgical indication, what exact dental procedure and what invasive surgeries. That is one part, and what congenital diseases. That is second part. So this is just the second part I'm putting here. That first is any prosthetic cardiac valves materials. She said in regarding congenital heart diseases, unrepaired cyanotic congenital heart diseases, or completely repaired defect with prosthetic material or device within 6 months after procedure, repaired diseases, but still they have residual defects. Okay. And next, what they mention is, this is very crucial point, that history of previous infective endocarditis. And fourth is cardiac transplantation. So the acyanotic ones, for they are the prophylaxis is elective surgery prophylaxis is not recommended. Okay. So that was correct answer. So actually I'm coming near to end. So this is just a quiz, and severity of cyanosis in TOF is directly proportional to Dr. Deepak, Dr. Abhinav is there.
Severity of pulmonic stenosis.
So you agree here? Yeah. So you don't go with first answer, no?
No, ma'am.
Okay. So I actually end my talk here, but I want to highlight few things, that there are different major topics connected to this topic. I mean, what I mean is that fetal circulation can be asked in basic sciences table. So the basic like physiology related question, or if you get an opening question of congenital heart disease patient, let it be adult or child, so it can be asked at that table also, retrogradely. So, but few things that we have not covered are, we have covered fetal circulation, but we have not covered fetal oxygenation. Okay. So what I meant to say is the comparison between HbA and HbF in oxyhemoglobin dissociation curve. Those also can be asked when you are, you are facing the question about fetal circulation. Secondly, the basic surgical procedures. I mean, not, BT shunt, and the names and basic surgical procedures that you should know. Thirdly, there will be another topic, between the differences in physiology in adult and neonate, but differences in adult heart myocardium and neonate myocardium. What are the differences? So that is also you should read. And in one textbook, I actually found they had asked about Fontan circulation, and I myself had never read it. So by any chance, do you know? I mean, it is really a bit complicated thing, but I think you should. It's worth that you Google about it and read it. Few things, at least 4-5 lines. So it is basically something about, yeah. If you know, please go ahead.
Yes. Sorry, ma'am. If you want to continue.
So it is what I realized is it is basically univentricular physiology, and where the ultimate output, it depends upon adequate venous return.
Yes.
And so there was, I think it's which textbook regarding EDAIC, I do not remember right now, but they had also asked that what are the concerns if you face the child with Fontan circulation.
Fontan circulation. Yes.
Yeah,
No,
but this is
mentioned in podcast only. It's mentioned in podcast.
Okay, so if you have that book, I think just go ahead with that explanation. That would be
so
great.
In Fontan circulation, if you allow me to.
Yeah, please.
Yeah, so basically it's a single ventricle circulation. So the patient, the kids, if the certain conditions when the kid has like only one functioning ventricle, like the hypoplastic left heart syndrome, tricuspid atresia, only the one ventricle is there to deliver the blood to the blood body. So the venous return comes directly to the pulmonary, through the pulmonary artery to the left side of the heart. So it is done in the 3 stages. First stage, they create the Blalock dissection, in which they connect the subclavian artery to the right pulmonary artery. In the second stage, the Glenn shunt, which connects the superior vena cava to the right pulmonary artery. And in the final stage, they do the Fontan circulation, which connects the inferior vena cava to the right pulmonary artery. And now the blood flow from the systemic venous return is coming directly to the left side. Now this venous return is dependent on the transpulmonary gradient, which is the systemic venous pressure and the difference between the systemic venous pressure and the LA pressure. So we have to maintain the this transpulmonary gradient, which can be disturbed by the positive pressure ventilation. Anything which increases the pulmonary pressure will causes this systemic venous return to reduce. So while in studying these patients, we have to minimize the positive pressure ventilation. So regional technique is preferred. We have to maintain the IV fluids, and
Okay.
so these are the concerns for the Fontan circulation, basically.
So that was good answer. I mean, very good answer. So I just wish to tell that if you are giving offline exam, I had given offline exam in Germany. So the sooner you pick pen and paper, it is easier for you to classify and think about further points. That's one thing I wish to tell. And if one examiner gets 12.5 minutes, so as the 5-7 minutes, they definitely can go into tougher questions. So I had been asked about, say, a patient post cardiac transplant. So I mean, those are really, but that means that we have answered at least the basic things clearly. So I just wish to say few things that we can actually revise through the books we had read for during our earlier MD/DMD examination, because that is the quickest thing we can do, and we can just go through the recommended EDAIC books to see what additional question and what additional points they have asked, and that would be the fastest way to study for the EDAIC. That was I think this was the last slide of my presentation. So anything, there is something in chat box that I will see. Crying will increase infundibular spasm, and yes, he's right. Crying will increase infundibular spasm, and it will cause RVOT obstruction, and then it will trigger cyanotic spell. That he has written correctly. Yes. Okay. So anything else, or we can stop here? I mean, any feedback you wish to say or any suggestions? I'm just eager to know that. Dr. Geethu, Dr. Deepak, or anybody else.
It was a very nice class, ma'am, and I got to revise many new things. Thank you.
Yeah, I'm glad. I also revised many new things for this class.
Presentation.
Hello.
Hi, I'm Dr. Modi here.
Yes, sir. Good evening.
I just wanted to ask you regarding clinical side, like we have one clinical case in exam. So still confused, we have to read a podcast for the clinical cases, or we have to find other master pass for the clinical case?
Okay. Sir, my theory and my suggestion, I will tell you that if you see the podcast, it's difficult without revision. It is difficult to remember many things. First of all, okay. So I gave exam in 2014. So that time the podcast books were not available. There were some different books for which were recommended for final FRCS. Okay, but similar ones. Yes.
Barker, I think, right? Julian Barker.
I cannot remember the authors, but what I've realized is that you plan in such a way that you have to revise it 2 to 3 times and underline with highlighters. And like, for example, congenital heart diseases, if just few things you have to remember, and then you go ahead and just brush up the few things from the next level things from the podcast. But regarding physiology and pharmacology, it is difficult to revise from our MD/DNB books because it is very vast.
Yeah,
And if you,
physiology,
yeah,
pharmacology is that it's podcast or master pass is okay.
it
But
is
the
beautiful.
clinical case, yeah, but the clinical case as a podcast final, suppose cardiovascular, when we start cardiovascular, it's very extensive and we're not understanding how to answer during the exam because any clinical case will come with the multiple comorbidities. Okay.
But
And
sir, you have to just answer the way you answered for your, MD/DNB, because every clinical case by time to utter, points start with what happens when you face any case. You take history, evaluation, then examination, then
yeah,
investigation, and when you see all these things, you get concerns. When you get concerns, you set your goals, and then when you set goals, you prepare few things, then you decide of induction, maintenance, monitoring, analgesia, and extubation. So if you start this point wise, I think it's the same way for clinical table. It's the same
okay.
way. Yeah, but do not, you cannot skip the podcast question. At least 2 times you have to read those books. That is very important. Yes,
Even find the
and
podcast.
for physiology, there are some typical graphs they ask. So those graphs you have to know.
That is in Plunkett, I think.
Yes,
Yeah.
yes, yes, yes.
In Plunkett, that kind of graphs are there.
Yes, but what I feel is the units we practice and we remember are not the same in Indian. They are different, and then European. So we have to mug up those few things. Otherwise, the rest everything is we can manage. I mean, there are some differences in kilopascal and millimeters of mercury, but that we have to remember. Other things we can manage actually. So I just wish to tell here that uh, I passed my exam in Erlangen, Germany. It was a 17% passing rate on that day. So, but when you give that exam, all of you should prepare in such a way that you have to pass it in first attempt only. What I feel is because that is the yes,
That's true, yeah.
because the next attempt that same zeal does not remain, and the fees are also not that low that you can appear many times. Uh, so I think we can do that. I mean, if you study these books and revise, first attempt we can clear exam.
Thank you, doctor.
Yes, I think I can end the meeting. Best wishes to everyone, and suggestions and are always welcome. And uh, we can be active through the WhatsApp group as well through this Medusis gas platform. Thank you.
Thank you.
Thank you, ma'am.
Yeah.
Thank you.
Dr. Sharvari, are you going to end the stream on YouTube?
Yes, I wish to answer.
Yeah, thank you.